So without further ado, I am going to introduce our very first speaker, and this is Rebecca Shoosmith. Rebecca is the Acting Chief Executive of Jones Trust, and Rebecca will be giving us an overview of the report, I Want My Life Back, which was published back in December 2020. We were delighted to be able to collaborate with Jones Trust on this, and we know how extremely important this piece of research is for patients, and it focuses very much on the patient's perspective. Although it is from a cervical cancer patient point of view, I do want to stress that the findings are very relevant to anyone that is living with and beyond a cancer diagnosis with pelvic radiation disease side effects. So without further ado, I'd like to say welcome and thank you for joining us today, Rebecca.
Thank you very much for having me. I'm delighted to be joining you today. I believe someone will have my slides, actually, if I could have them up, please. So as I was introduced, I'm Rebecca Shoosmith from Joe's Cervical Cancer Trust, and at the moment I am Acting Chief Executive, and I've been in touch with PRDA for a number of years, so I'm delighted to be here to speak to you. If I could have the next slide, please. So we were super keen to find a way to partner with PRDA around long-term consequences. For those of you that may not be aware, how this report came about was that actually we'd already done some work around the long-term consequences of cervical cancer and its treatment in 2017. We ran what we believe to be the largest survey of its kind, with 866 women taking part. And it confirmed and highlighted the significant needs and gaps in care when it came to the types of issues people were facing after treatment. So the report made some very bold and ambitious recommendations at the time. And we found that actually 2 to 3 years on, we'd sort of really not made the headway that we would have liked. And we needed to understand a lot more about just what was being provided to patients. And so it seemed, ideal to join together and look at doing a report with PRDA. So what we did to go further is we looked at the stories from our support services and what we gained from our original report. And we also carried out 18 in-depth interviews with patients. We also interviewed healthcare professionals working within late effects and radiotherapy across the UK so that we could get a more rounded view. And then significantly, we issued Freedom of Information Act requests to NHS trusts and health boards across the UK, just to try and understand actually what was out there, what was being provided to patients, because we just didn't know. We knew of some great work going on, and we were hearing through our support services that there was some massive gaps. Next slide, please. So what did we ask them? We asked them, does your trust have specialist clinics for patients who've had treatment for cervical cancer and are experiencing the late effects of pelvic radiotherapy? So that was, bowel or urinary issues. Does your oncology team have a standardized method of identifying people with PRD for referral? So are they using an Alert B tool to support the clinical assessment of patients, finding suitable referrals for them? Does your radiotherapy centre ensure that patients are aware of possible acute and long-term side effects prior to treatment? And if so, how are they told? Does your radiotherapy centre offer a range of materials to support with acute or late side effects of radiotherapy? So are there booklets, symptoms checklists, toilet cards? And if so, what do you provide? And does your gastroenterologist and dietitian use the PRD bowel algorithm published in the Practical Management of the Gastrointestinal Symptoms of Pelvic Radiation Disease? So we were really trying to just dig into what was out there. Next slide, please. So the results were not quite what we were expecting. We knew that there was an issue, but actually we learned a lot around the process that we went through. So actually not each trust delivers radiotherapy. So therefore, it was very hard to draw lots of conclusions over the percentage of who had or hadn't, who didn't give excellent care. So there was learnings for us in how we might do things differently and ask questions differently. There seemed to be different methods used when identifying patients. So some used the alert bead style tool or questions based on it, while others said patients would be referred to a specialist such as a dietitian or a gastroenterologist, and others didn't use any kind of standardized tool at all. We found that there were 11 services in England, with 2 being planned, 1 in Scotland, 2 in Wales, and 1 in Northern Ireland. So this has given us great concern that actually there is widespread systemic failures across all parts of the health system. Next slide, please. So this has led us to some new recommendations, that actually all patients are to leave radiotherapy with a treatment summary that's also issued to their GP with details of their treatment, potential side effects, and where to access appropriate referrals and support if they experience them, if they need their support. The centres of excellence for PRD should be established to support diagnosis and referral for patients, in addition to building the specialism through developing training across the workforce, trialling new treatments, contributing to the knowledge base, and providing a central resource hub for clinicians. Essentially, we've seen that a lot can be done in the NHS. We've seen how long COVID is being taken seriously, and that services are being set up for that. So why can that not happen to such an extraordinarily large group of people who have been suffering with significant effects after radiotherapy? We're calling for NICE guidelines on the diagnosis and management of late effects of pelvic radiotherapy, or on the management of cervical cancer, because actually we don't have any NICE guidance for the management as a whole of cervical cancer, including follow-up pathways for identification and treatment of symptoms following radiotherapy. Next slide, please. And there's one I think we've probably seen many times now in different reports, a tariff for the late effects of cervical cancer to be developed within the NHS to fund much needed clinics and services. And for new research to be conducted to assess current understanding of PRD among professionals across primary and secondary care, in addition to long-range studies looking at the experience of patients. More understanding is needed, and actually understanding who understands and who doesn't is needed. And professional bodies and societies, including the Society of a Society and College of Radiographers, Royal College of Physicians, British Society of Gastroenterology, and Royal College of General Practitioners, to identify opportunities where teaching about toxicity following radiotherapy can be included in medical training, especially for primary practice and gastroenterology, where patients may present with quite complex symptoms. Next slide, please. So the partnership between Joe's Cervical Cancer Trust and the Pelvic Radiation Disease Association was incredibly important. Now, as I mentioned, actually the 2 charities have been great pals for a number of years. And certainly I've worked a lot with Jane, and we were always keen to find ways to support each other and work with each other. And we've done that in a very sort of just ad hoc friendly kind of way. And actually, this was a real opportunity to do something together that was structured and outward facing and showed the alliance and the partnership clearly. How we benefited was that PRDA raised different points, different things to consider within the report that we perhaps might not have thought of. And so they were a key resource throughout, and were involved with the discussions from the start, so that we were able to gain from their experience and their insights. So it was hugely important to us. Unfortunately, we had begun these discussions on the report and how to partner just prior to COVID hitting. And so, of course, as you can imagine, the impact of COVID meant that the project was started a long time ago, but the pandemic put a huge strain on both of our organisations and those working in the field of PRD. And so this put the brakes on quite considerably. So therefore, there's a need to to now pick up this data quickly so that it is still relevant, and to get it out there as widely as possible. But aside from that, the partnership worked extremely well, we felt. And so we're looking forward to more opportunities to continue the partnership in the future. Next slide, please. And where we are in terms of our progress is that we've already been sharing the data with our networks. We jointly met, the two charities jointly met with the Living With and Beyond Cancer team for NHS England, which again just continued to highlight the cause and also to find new pieces in the puzzle, because this is quite a complex situation that we're trying to influence. We've been talking to other charities where pelvic radiotherapy is part of the treatment, and we hope that we'll be setting up some meetings with those charities in the future to see if there's some simple actions that we can take jointly. Now, some years ago, PRDA and Joe's met with a number of other charities, and I think potentially one of the reasons why it didn't get as far as we'd all hoped is that actually it was incredibly ambitious, and we were perhaps aiming a little too high at that point. But sometimes by taking very simple actions together in partnership gets the message out in the way that you need it to. So it is definitely part of our planning for the next financial year. I've spoken to the chair of the APBG on cancer about the importance of those recovering from pelvic radiotherapy. And we're talking to cross-party groups, as well as the England Cancer Policy Programme team. So there are many more meetings and actions that we plan to take in the future. And we're looking forward to continuing to partner with PRDA in the future. Next slide, please. So thank you very much for listening to me today talk about this fantastic partnership that's actually been going for a lot longer than it has been sort of publicly behind the scenes. And I'm just absolutely thrilled to be here today and thrilled that we are continuing to work together. Thank you.
Thank you, Rebecca. That's really, really, really insightful. And I know we've very much enjoyed working with Joe's Trust, as you said, for many years, and obviously very much so on this particular piece of work. We've had a couple of really good questions come in, if that's okay, if I can pose them to you. Fiona's asked a really good question, actually. Are NICE actually planning to develop the PRD guidelines? Do we have any knowledge on that or yet?
I'm actually not sure whether they have plans to. I know that there aren't at the moment. Technically speaking, one could say that PRD comes under the long-term management of long-term conditions guidelines for NICE, but actually it just doesn't. It doesn't. That doesn't cover it. It doesn't go far enough. So there is a real need, and for us, it was actually quite shocking for all of the people that were working on the report to find how little there was out there in terms of sort of structured and agreed approaches. It was all about these incredible people who were taking up the charge in their area, these incredible clinicians who saw a need and were going for it and finding ways to connect with each other. But what it's meant is that those services are incredibly vulnerable because often they are dependent on a single person with that passion. And so if that person leaves or their work takes them in a different direction for whatever reason, it means that those clinics that they've set up, those services end. And we've seen that, sadly, in the time that we've been writing the report. We've seen a couple of great bits of work that are being done close because funding stopped and there was nothing more that they could do to continue. So it's quite shocking how fragile the support for PRD really is.
Yeah, we hear that a lot, and I think that's a really, really important point about the fact that it is driven by clinicians and their interest and where they geographically are placed in the country. Which of your recommendations do you think would have the most impact?
That's a very good question. I would say, I think for us, in our hearts, we would love to see centres of excellence. We know that it's a massive ask, but really that's what's going to shift things. If there are centres of excellence, then you have people who take an interest. It prompts research. You know, it promotes the condition, and we know that it can be done. It's been done. You know, there is a late effects breast clinic for breast cancer patients treated with radiotherapy. So we know that it can exist. Ideally, of course, the tariff. But that, I mean, I feel like we've been sort of chasing this mythical recommendation for a number of years now, and it's incredibly complicated. But the ideal, the real wish is to see centres of excellence where GPs know where to refer their patients. They're not being sent back to oncology to be scared witless that they have cancer again. That actually there's a recognition of that. So a lot of it is very interconnected, increasing clinicians' knowledge around it, particularly in primary care, I think, you know, is also incredibly important.
Thank you. And I have a question from Susie. She had her own radiation treatment 32 years ago. And her question is, how are people who have had cancer treatment and radiation in particular that many years ago catered for with regards to being able to access support so many years beyond their treatment? You know, do you see that as being a challenge?
It's absolutely, most certainly a challenge. And this is where, you know, and I don't want to sort of down talk the poor GPs, but actually, you know, they are required to have a very broad knowledge of an awful lot of things. And actually, for a patient coming, I mean, 32 years after treatment, the GP would not necessarily anticipate that being a result of radiotherapy, when actually we know that that really can happen. That's, you know, sort of 20, 30 years after treatment, some issues can then present at that point, particularly with the bladder. And so actually, where I think we as Joes can have influence is with the patient. So actually, if the patient knows to go into the GP and say, I had radiotherapy 32 years ago, I need a referral, then that actually kind of notifies the GP that there's an issue, and they can hopefully respond accordingly. But it is a real challenge, yes.
Thank you. Unfortunately, we've run out of time, Rebecca, but thank you so much for joining us today. And again, thank you so much for collaborating with you on that, for us being able to collaborate with you on that brilliant and fantastic piece of work.
An absolute pleasure. Thank you so much for having me. Enjoy your day.
Thank you.